Okay, now we're going to work on the pelvic girdle and the hip, and quite a lot of information to go through, but you'll get it as we go through. By the way, this is chapter 18 and 19, I believe, not 17 and 19, but take a look in your reading. Um, so as we look at the pelvic girdle, important to understand that we are looking at several different bones. We are looking at the sacrum, which is those five bones that are fused together. We are looking at the coccyx, which is at the end of the sacrum, and then the two hip bones on either side. And the two hip bones are connected by joints to the sacrum, or what we are going to call the sacroiliac joint or sacroiliac joint, as well as the front of the pelvis, which has the pubic symphysis. There's the coccyx. There's the bone. We got one on either side. So we have some articulations. We have a right and left sacroiliac joint. We also have the symphysis pubis or pubic symphysis. And we have a lumbosacral joint where the lumbar vertebral column comes in contact with the sacrum. Couple of things that are important for you to remember. The pelvis serves several functions. The first is to support the weight of the body through the vertebral column. All of that weight from the top of the body comes through the vertebral column into the pelvis. It supports and protects the pelvic viscera, all the different organs that are in there. It provides an attachment for many muscles, which we're going to see. And of course, it makes up the bony portion of the birth canal in females. And looking at the sacrum, and it is easy to see that we have one large bone in essence, which is technically five bones that are fused together, which articulate with the ilium of the pelvis. And it is the sacroiliac joint or SI joint, which is non-axial. That means there is no movement around a joint. The ilium is divided up by a number of important prominences to be aware of. We have the iliac crest, which is up at the top of your hips, the ASIS or anterior superior iliac spine. We have the PSIS, which is the posterior superior iliac spine, and we have a greater sciatic notch, which is a big open area. I will show you some samples of the pelvis when we go to lab. By the way, the ischial tuberosity is your sit bone, and that's where we tend to see a lot of pressure sores in areas. Okay, so ligaments, lots and lots of ligaments, important part of the structure needed to prevent a lot of excessive movement. So some people have SI instability. Down around the SI joint and the lumbosacral joint, there are lots of ligaments to help reinforce and keep that nice and tight. And that's all that I need you to know about those ligaments. The pubic symphysis, there on the front of the pelvis, it doesn't intend to move much at all except during childbirth. It is a fibrocartilage disc that connects the two bones on the front of the pelvis. It is an amphiarthrodial joint, which means it allows very, very little movement. The lumbosacral joint is between the fifth lumbar vertebra and the first sacral vertebrae, and we're going to take a look at something called the lumbosacral angle in class, which should be right around 30 degrees optimally, and we're going to talk about what happens when it's more or less than 30 degrees. The motions of the pelvis are the following. Anterior pelvic tilt is when the ASIS, the anterior superior iliac spine, is out in front of the pubic symphysis, and I will demonstrate this in class. Posterior pelvic tilt is when the ASIS is posterior to the pubic symphysis in tilt, and I will show that to you. The pelvis can also do lateral tilt, in which the iliac crests become uneven. One drops down, and one is up higher than the other. I'll show you some things in class. Pelvic rotation is when one side of the pelvis is in front of or behind the other in relation to a plane in front of the body. We're going to be spending time talking about force couples in lab next week, and the force couples relate to those muscles that work together to create the motions of the pelvis. Force couples are two muscles that create rotation in opposite directions to create a turning effect. Okay, the anterior pelvic tilt is created by, on the posterior surface of the trunk, the extensors, trunk extensors. So we have your erector spinae, right, pulling up, and then on the front side of the body at the hip, we have our anterior hip flexors pulling down. This causes the pelvis to tilt front towards the front or anteriorly. Posterior pelvic tilt involves on the anterior side of the trunk and your abdominal muscles to contract and pull up, while in the posterior surface of your hip, your extensors cause the pelvis to tilt posteriorly. So the posterior hip extensors are pulling down. The anterior front trunk flexors are pulling up. Lateral tilt is a combination of the erector spinae and the quadratus lumborum working together on one side to pull up, while on the opposite side, the hip abductors are pulling down. You'll understand this more when we work on some of this. All right, now in looking at the hip, just some general information. It is, by the way, when we talk about hip motions and the hip joint, we are making reference to movement of the femur. The hip joint is a ball and socket joint. It is triaxial, so we know that means it has three planes, three axes. It moves into flexion, extension, and add hyperextension here. It also moves into internal and external rotation, as well as producing the movements of AB and adduction. It is quite a stable joint, and for that reason, we don't have nearly as much range of motion as we do in the ball and socket joint of our shoulder. If we look at the bones, we have to identify how the pelvis and the femur come together. So again, we have the ilium, the ischium, and the pubis of the pelvic bone. Ilium, ischium, and pubis. We also have some other key points to understand. We have the acetabulum, which is this big fossa, if you will, for the head of the femur. We have the obturator foramen, and we have a greater sciatic notch. On the femur, we have the head of the femur, the neck of the femur, which we're going to talk about in class. That is very cancellous bone and is easily fractured, especially in elderly patients. We have the greater trochanter and the lesser trochanter. The greater trochanter you should be able to palpate pretty easily. Also on the distal end of the femur, we have the medial condyle. On the inside of the distal end of the femur, we have the lateral condyle on the lateral surface, and then we've got epicondyles medially and laterally, which are above the condyle, obviously, and then the linea aspera. Linea aspera is a raised portion we'll take a look at on the femur that creates an attachment for muscles. Also worth mentioning is the tibia, because the rectus femoris, which controls motion of the hip, is a two-joint muscle. Therefore, it crosses the hip as well as the knee and inserts on the tibial tuberosity of the tibia. Lots and lots of ligaments in the hip to keep it extremely stable, but again, no need to memorize. Now, muscle in the body, and that is a two-joint muscle. So I'm not sure exactly why I said, yeah, the rectus femoris is the only set of quadriceps that crosses the hip joint. The other ones are just controlling the knee. Sorry for the confusion. All right, so rectus femoris, iliopsoas, sartorius. Okay, the adductors, those are going to be on the inside surface at the hip. We have the adductor brevis, the adductor magnus, and gracilis. Let's see, what else do I want to tell you about that? I think the pectineus also contributes to adduction. We'll take a look at that in the lab. Another adductor is the adductor longus. And we have extensors. Your extensors are going to be on the back side of your hip, your gluteus maximus. And then we have three sets of hamstring muscles, the semimembranosus, the semitendinosus, the biceps femoris. Okay, we're going to see those muscles again. Those hamstrings are two joint muscles, and we're going to see them again when we talk about the knee and flexion of the knee. But for the hip, they produce extension. There are also deep rotator muscles that are in your book, and we are not going to be building those. I'm not going to require that you memorize those or know those, but they contribute to extension. We have abductors. We have out on the outside edge of the hip, we have the gluteus. Fascia lata is a two joint muscle, so it's going to have some impact on the knee as well. And we also have medial rotators to turn the toes inward or roll the femur inward. The gluteus minimus is the medial rotator. And for lateral or external rotation, we have the gluteus maximus and our deep rotators.